And we are live. All right, so it's about 7:30 p.m. Tbilisi, so good evening to everybody joining us. My name is Zaki Azmi, and I'm a 6th-year medical student, class of 2020, and I'll be hosting Suture Sundays today. So we have two surgeons today, Dr. Tutor and Dr. Lika. We'll start with Dr. Tia. So Dr. Tutor is a vascular surgeon and an interventional radiologist. She was the former course director for BAD, and she also is involved with research concerning arteriovenous malformations. And with that, I would like to bring her in. So. There we go. We're live. Good evening, Tia.
Hi, Zaki.
So, first of all, how are you?
Great. Thank you for inviting me. It's a great honor to join.
And thank you for accepting the offer as well. So, I have just given them a brief introduction as to who you are. We can start off by, could you tell us what your profession is? Could you state your profession?
Good evening, everyone, once again. And for those who don't know me, my name is Tia Todua. I'm an interventional radiologist. I work with a team of vascular surgeons. I'm considered to be an endovascular surgeon, which means we do the procedures on blood vessels, excluding internal and coronary vessels. So everything else is our field. We do both endovascular, which is percutaneous approach, and open surgeries and hybrid surgeries using both techniques.
Okay, perfect. So, Tia, could you tell us, what made you lean towards vascular surgery in the first place and interventional radiology? What was it that appealed to you?
Honestly, I didn't pick this field. I always say my goal when I studied in a medical school was to be a cardiologist. And when I was at the time to pick my residency, I met with a wonderful person back in time. He was one of the founders of medical radiology in Georgia. His name was Odwa, and we had a conversation. And at the end of the conversation, he offered me a spot in a residency in medical radiology. And so I agreed, and that's how my journey in medical radiology started. A few years later, late in my residency, I met with another person, vascular surgeon, who after 15 minutes of conversation offered me a spot fellowship in the vascular surgery.
Oh, okay. And hope at this point,
how I started vascular/endovascular fellowship program, and I've been very fortunate to have worked with those people and who shaped me as a doctor, as a physician, as a person who I am today, and I'm very grateful for that opportunity.
Great. So it's safe to say that no regrets, right?
No.
Okay. Great.
Out again. Hard.
Because the entire series of these interviews are basically geared towards second years, people, students who are in their preclinical subjects. So could you give us an idea as to what kind of patients you would see on a day-to-day basis?
Yes. So most of our patients we would see, there were cases, those were the patients with several comorbidities, chronic illnesses like diabetes, coronary artery disease. Most of the patients were with the peripheral artery disease, chronic or acute ischemia of extremities, mostly lower extremities. Those were patients, mostly male patients. the patients with chronic illnesses like diabetes, kidney failure, AVMs, arteriovenous malformations, and I'll talk about it a little bit later. Varicose veins. Yeah, those were mostly the patients I would see. The day would start depending on what day we had. It was either outpatient surgery day, would be 12 to 14 to 16 hours. We would see the patients twice a week, outpatient clinic. And then the other days were the surgery days that were the longest and the hardest days. And yeah, we use the imaging studies called X-rays to see the vessels, and either using the catheters open or repair the arteries or the veins, or close them whenever needed.
Okay, and what? Sorry. So moving on to BAD. I mean, obviously, we're going to come back to the AVM, and we're going to come back to you have a few videos and cases you want to share with us towards the end of this. But then let's just go back a few steps. And most people wouldn't know this, but you were there from the very beginning of the USMD, and you were the course director for what we call BAD, Becoming a Doctor. So when you designed that course, what did you have in mind in the first place?
When I first got the offer to design Becoming a Doctor, I thought it was an impossible task, because this subject never existed in Georgia. They never had any syllabus or curriculum at Emory. So I had to think for over a year.
Plus, it's a very intense title, isn't it? Becoming a doctor. There's a lot of pressure. Just with
I had to include everything that doctor in training needs to know, and it had to include the humanities. It was a must, and it had to include everything for patient review, taking a patient history, examining a patient. So it was I would say a daunting task, with a great team of people that helped me design the course with the from Emory side faculty, Dr. Mary Jo Lakovic, Howard Kushner. I'm not sure if you know them. He was with us at the beginning. Dr. Georgi Georgobiani, class of 2020 and 2019 knows him. Was one of the founders.
Very intense personality,
Yes, Rima Riashvili. And of course, it's a course that consulate needs to develop. So we kind of set up a basic foundation of the course that the other people after me shaped it and developed it. So I was at the beginning, and from 2012 to 15, and then Dr. Dominguez was right after that, right?
So was this your first time teaching?
I would say yes.
So what influenced the decision from like being a practitioner to becoming a tutor?
I wouldn't say it was easy, because when you teach, you gotta revise from the very beginning. You start, and it was forgotten, what you studied in the first year or second year. What helped me a lot was the experience being a student when I was a medical student. It was a little bit different. The life was different at that time, but the challenges that I was facing first, and the problems the system had, try to put that up, bring that, and solve those problems, of course, with colleagues. One of the main problems and the challenges we had when I was a student was we wouldn't see the patients. We that clinical experience very first years. First to throughout the third, 4th year.
Mm-hmm.
So, but would be better. The students will have better understanding what they're studying
Mm-hmm.
if they see the patient at the end of the day. So that's how we started shadowing
Yeah.
of during the BAD.
Mm-hmm.
At first, extracurricular, and then it was very successful. It motivated the students a lot, it inspired the students, and then we put it in a plan, in a curriculum.
Yeah.
I had opportunity to work with incredibly talented young people back in the time. They were students.
Mm-hmm.
Vika,
Yeah.
Nick,
Yeah.
Lado, and Lika.
Yeah.
They work. They did a tremendous work
Mm-hmm.
together with us, and they put a lot of effort for this course to be the most favorite
Mm-hmm.
course.
Mm-hmm.
Students.
Yeah.
I don't know. I hope it's the same now.
Oh no, I can attest to that. I was in the class, and without a doubt, I mean, obviously BAD has evolved with every new teacher we've had, and it should. That's the only way it gets better. But then I can attest, hands down, that at least when you were teaching us, it was a very hands-on approach. Because I do remember there was one time where while you were working at university, you came to class one day with stents, and you made an incision, and you taught us how to suture like in class, like without any warning or anything. And then before we knew it, we were having contests who had the fastest hands. So it was a great experience overall. You were mentioning problems with the system and challenges you face as a student. So here's a question. Now, in your opinion, in your experience as a physician, what do you think is one of the largest barriers in patient care, and how do you think we can address it?
So to me, I had a different challenges back in the and see the patients. So we were afraid of the patients when we first saw them.
Yeah, it's scary.
Yeah, and with the program we had different challenges since it was international class. A lot of people wouldn't speak the language, so it was a lot.
Yeah.
And the students, we didn't know how to behave in front of the patients. We didn't know when to say hi, what to do, where to put the hands, whether should we knock at the door or not. So I put that in the class, and to teach everything the student should know, the medical student, and not to be afraid.
Yeah, and those problems are obviously multiplied when you're in the operating room, right? Isn't it?
Yes.
Yeah.
Yes.
It's like you just take one step to the right and you get yelled at. So it's like it's a learning experience. It is a learning curve. There is a learning curve here. So moving on to your the research, the arteriovenous malformations. What can you tell us about that?
The AV malformations are called the arteriovenous malformation. Is one of the rare pathologies that you see in your medical career, and they're very complicated to treat because most of the time they're undiagnosed unless they're symptomatic. I focus on congenital pelvic AV malformations that are even rare. And they have high index of morbidity and mortality. I thought it would be interesting to show you. I mean, I can talk about it, but now it would be interesting to show you what it looks like.
Stage is yours. Go ahead.
Okay, let me bring the video. So the AV malformation is the abnormal connection of arteries and veins that excludes the capillaries, and they're a big problem. So this case is 42-year-old female who presented to our hospital with heavy bleeding. So on the right buttock, she had ulcerated skin, and this is what she presented with. It's a high pressure AV malformation. She that was untreated for years, and so let me see what it looked like on a picture. Okay, I'll show you. and at the beginning of the surgery, and then after the surgery. So what we did with the patient was we closed the feeding arteries percutaneously using special coils.
Mm-hmm.
Okay. So this is what it looked like. The right buttock was 3 times bigger than the left one, and it was bleeding. There's a small ulcer here.
And this patient
this is what
for years, is what you're saying?
Yes, for years. She didn't know she had a AVM. This is what it looks like. Whatever the color thing is, it's the AVM.
Mm-hmm.
And it was the feeding artery was almost the size of common iliac artery.
Wow.
Yeah, that's why it was pretty dangerous to treat surgically. So we closed it. Let me see. Here, we closed it. There is no vascularization, and then we tried to surgically remove it. And in the end, this is what it looked like. There's no AVM. And, you know, it doesn't look as pretty as the left one, but...
yeah,
but we improved the quality of her life. She could sit, she could walk, she could do her daily tasks. And we followed up for 3 years and with no recurrences. So these kind of cases, we had several, and they're pretty interesting to work with. I told you the short story, but several comorbidities, and yeah, it was fun, interesting times.
So that was a very interesting case. Before we leave, could you you have been on maternity leave, right? For about
Yes.
2 years.
I have 2 bosses at home. 3 old and 15 months old. I have a full time job plus night shifts.
Wow. Okay. So I can't imagine what that must be like, but.
And working in the surgery and working 3 jobs that I work for. So yeah, I'm on a maternity leave right now.
Yeah. Okay. And my question to you would be, how do you think maternity leave, especially if it's extended, how do you think maternity leave affects your career, if it does have any effect at all? I mean, obviously, it gives you time to, when you're not in the hospital all day, it gives you time to like look back at your experiences and reflect on it. Maybe you could come back as a better physician. But then, in your opinion, how do you think it changes the way you look at medicine?
It changed a lot. Everything. It's like if I start over, it's like learning to walk again.
Mm-hmm.
No, but yeah, it does. So when I go back, I gotta get in the training again and walking again, and then start running.
Are you looking forward to it?
Yes, I am, very much.
Great.
Yeah.
I bet the patients would as well. I mean, okay. With that, Thea, I would like to thank you once again. Thank you very much for doing this.
Thank you. Thank you.
There was at least one person out there, apart from me, who found this valuable. It was fun chatting with you after a long time as well. We go way back, so yeah.
Yes.
So with that, if there's anything else you would like to add before we leave,
I'm very happy and super proud of the program where is it now and where you guys are now and how everyone has grown up. I mostly, unfortunately, I only know 2019 class and the class of 20, and my friends keep me posted, keep me updated. I feel super proud that I was once part of it.
Yeah, I should mention that anybody watching this, like our lower-classmen and stuff, Thea has come through not just in the classroom. She has saved us outside of outside of the university as well. I mean, when we came in, you know, looking for medical attention or advice, that kind of thing, when she was working at university, she's been a great help and a great person to be around as well. So with that, thank you very much, Thea.
Thank you. Thank you, guys. Those who have picked the program, so you're on the right track.
That's a good way to end this. All right, Thea. Goodbye.
Bye.
So, we're still rolling. So we're going to be inviting Dr. Lika now. She's a pediatric neurosurgeon. Hello, Lika.
Hi, how are you?
So, everybody, this is Dr. Lika. I'm fine. How are you?
Good, thank you.
So,
I'm really fine.
I don't know if you want people knowing this or not, but just off, I did introduce you as a pediatric neurosurgeon. Dr. Lika is also involved with research with posterior fossa tumors in the pediatric population. So I don't know if you want other people knowing this or not, but then if you guys can look at her screen, you'll see a leather jacket in the background. There is video somewhere on the internet of Dr. Lika doing stunts on a Kawasaki Ninja, like a motorcycle, right?
Yeah, sure.
Yeah. So yeah, if I recall, it wasn't just wheelies. You were like standing on the on the actual motorcycle, hands-free. So,
yes.
Yeah, so she has a hidden badass side to her as well. So we will get back to that. But then, to start off with, could you tell us what you do professionally?
So, hi everyone. If somebody don't knows me, my name is Vika. Surname is Korbaladze. It's Georgian and a bit hard to pronounce, but general it's like that. So I'm a neurosurgeon. I have finished my medical school and in Georgia, but as well I have passed some of the fellowships around the world, like in Canada, in Austria, in Turkey as well. So I try to get as much information as I can for my country and to start over some new stuff about the neurosurgery. So my main field now is the pediatric neurosurgery, but before that I worked about like 8 years in the adult, and I have made my residency in the adults. And so I'm kind of familiar with both of them, with the children and the adults as well. So both of them has some specifics to work with, but both of them are fun. Like I can say that to work with the patient's brains, it's always fun because you never know what you are getting after the surgery or after vaccination and everything like that.
Plus, there's a lot to discover in that field. Yeah, there's a lot we don't know. So.
Sure, sure, a lot of them, a lot, and it starts to develop really fast as soon as we have the new technologies and we have the new and it's great things to be done in your surgery.
So, speaking specifically about pediatric neurosurgery, what made you choose pediatrics? Like, you are involved in research that deals with the posterior tumors in the posterior fossa in the pediatric population. So, why pediatrics? And my second question would be, why posterior fossa? So.
Okay, so let's start with the first question. So, to work with the pediatric population, it's always really tricky because they are completely different. And they are completely fun to work with. We can say that it has like two sides of the coin as well. The first side is that the children is very fun to work with because they are laughing, they are like starting to give you some new, they are starting to give you a lot positive pressure on you, like you are starting to fun, you are starting to play with them and everything like this. But on the other half, it's completely different because all the we can say pathologies are going in a different way with the children. You don't know what you will get because in one stuff you are thinking that this will be really fun, everything will come out very nicely, and completely can turn over in one day. That's the children.
Yeah.
So, and regarding the second half of the question, why posterior fossa tumors? First of all, for me, the posterior fossa is always the most interesting part, because when you're working on the posterior fossa, you're very close to that particular part. When you are seeing all the nerves, when you are seeing all the different, you are seeing the medulla oblongata part of the brain when you are touching, and if you will touch it much, you can just stop the heart beating. And when you're working that particular area, you feel that you're working with the brain. And especially, unfortunately, I can say in the pediatric pathologies, we have more tumors in the posterior fossa than in the adults. And because of this, like, if there is more, you can find out more about the posterior fossa tumors, and you can do more things for the children.
Yeah.
That's why.
To sum up, it's a field of neurosurgery where you can make quite a difference, right?
Sure. Because like generally what we have in the posterior fossa, it's the astrocytomas, specific type of the tumors, which are called medulloblastomas. And especially medulloblastomas, they can be like several types, and you're very good research them. Because like if medulloblastomas can go really fast, and if you will try to understand their biology and their molecular part, you will do some research and you will investigate something to help. That's the general part.
Great. Okay. You mentioned something earlier about dealing with children. The first question I asked, and one of the things I learned from you specifically was how much a physical exam differs from doing it on an adult and doing it to a child. Obviously, you need to get it to behave and focus. Like, you know, performing a neurological exam is just it's a whole nother level of difficulty. The thing is, I've always gotten along with children. I have a lot of cousins who are like little, so I've always gotten. But there is a good amount of people, I would say maybe a majority of them, who feel awkward around dealing with pediatrics, like around children. They don't get along with children. They can't relate.
Yes.
Would you say that you've always gotten well with children, or did you have to learn it along the way? Because a lot of people put off with pediatrics because they see children, they're like, oh, I don't want to deal with that. But you know, it's a great profession, and you know, I wouldn't want people to be discouraged for that. So could you give us any advice for people who aren't really good at handling kids?
So I can say about that first of all, to deal with children, and when it got from the adults to children, it was hard for me because I understand how to get to the children. Then I just walk around the clinic for about 1 week to specifics of the different part, and then I started. When I started to interview children, I started to get different things, like the sweets, like the so much that each children in the in the department, they're coming to play, and I can understand a lot of things about them there, and it's really fun. But of course, in the first part, it was really hard. It was.
Quick question. Are you? Is my voice coming across clearly to you, Dr. Lika? Because you seem to be freezing a little. I can hear you. It's just that your video is a little laggy. Is everything fine on your end?
No.
Okay, perfect.
Yeah,
okay,
yeah. It's everything fine. Yeah.
Okay. So I mentioned, the first thing I mentioned when we brought you in was that you were like a daredevil on a motorcycle and everything, but then having a career like pediatric neurosurgery and at the same point in time being able to do things outside of life, like in your life, like, you know, stunting, for example, on a motorcycle, which is pretty epic. But then most surgery gets a bad rap for this, but medicine overall suffers from burnout. So
yes.
And could you illustrate like the difference between burnout in residency versus burnout in actual as a physician once you're out of residency? Those burnouts are very different. And could you give us any advice for dealing with it, for example?
Well, what I really want to say for this, for the like 5 year and the 6 year, especially when you're preparing for getting to the residency, and like this, that you're dealing with it takes whole like, several years when you're getting to the like residency and when you are getting to the medical school. So I can say one thing, that if I didn't have like the outside activity of like the motorcycle, like dancing, like singing, and anything else
You
besides
can.
the medicine, I would never.
Oh, great. Okay.
Yes, I dance and I sing.
Okay,
Yeah,
I'm gonna remind you of this. Okay. So continue.
yeah,
Sorry to interrupt.
sure.
It's just
Yeah,
okay.
sure. And if I didn't have that particular part, I would really just go off the medicine.
Mm-hmm.
Because I want to say one thing, like my last fellowship, which I 6 months in Turkey, the professor, who is one of the main inventors of the pediatric neurosurgery, especially the posterior fossa tumors and the specific pathologists like the spina bifida. So it's a specific pathology when you have the hernia of the spine in between the vertebrae. So it's that particular part, and you see mainly in the children. Even he was saying to me that even when you are a doctor and when you're working, like you have 5 surgeries in a day and everything, you have to have something at home to get over that particular. So it's different. Every student can have it's different. Somebody likes to go, somebody likes to do like scans. Somebody likes to do photography. Somebody likes to just go out and walk. Somebody likes yoga. It's completely different with each of you, but you have to have that particular part. My professor is playing guitar virtuosely, I can say to you. Like, he wouldn't be the neurosurgeon, he would be one of the guitarists in the world, I think.
Wow.
So, yeah, it helps you a lot. Because, when you feel the stress and when you are like, how many hours? I will just count just a second. 36, 48, 72 hours. When you're 72 hours in a clinic and you had only 6 hours of sleep in 3 days, and you had about 6 surgeries, the children, and then you feel that just can't walk. When you go out from the clinic, you must not take that particular part of you. So because you need something to do.
So
it can.
compartmentalization is what you're saying. You don't bring your home with you.
Yes.
Okay.
As well as you must not take anything from home to the clinic. So it must be two separate things. Like when you're entering the main door, everything stays out, and when you're coming out from that door, everything stays inside. You have to deal with that. It's the most hard part, I can say, in the medicine, but you can deal it.
Yeah.
I think that you can. Yep.
So guys, apparently after medical school it gets worse, but then we gotta compartmentalize and have hobbies is basically it, right? Have a life outside of medicine, something to come home to is what you said. Yeah. So apart from telling everybody to go out and get a motorcycle with a helmet, obviously, would you have any other advice for our students listening right now? They usually, most of them are probably from, I'm assuming, first year to about fourth year.
Yeah.
Clinical.
Get a hobby for yourself. It doesn't matter what it will be. It can be the reading, it can be like collecting something, it can be drawing, but not TV and not the TV shows. Why I can say you one word, because when you are starting to get to the TV, it takes a lot of time, and it's the main thing. Stuff, it's great. Like playing piano, playing guitar, doing yoga, going out for, you know exactly how many hours you can get for that particular part. But when you're starting to watch the TV, you just can't understand what is happening, because it can go like 7 hours like that you don't feel, oh my gosh, it's already 7 hours past. Not like that. You have to get everything in a shape. Like you have it like a routine.
Yeah.
You get up in the morning, do your task, go to the university or attend the classes onlinely. Then you have to have a break for some hours, like maybe 1 hour or 2 hours maximum, to get over to the shape when your like brain can feel again and can study again and start for studying and doing the homework. Because if you just go through that particular part, you will always have some like overthinking about it.
Yeah.
And yeah.
So to wrap things up, you mentioned that you had spent time abroad in different places like Canada and Austria as well. And you did mention a very important point, that even though you go abroad to seek knowledge and come back with knowledge and experience that can make the Georgian healthcare system better. Now, it's called the USMD program, and everybody here is hoping to end up in the States somehow. But then eventually, no matter where you end up, the thing is, you cannot be satisfied with the status quo. You need to continue improving, and the only way is to seek out different sources of information and knowledge. Is there a difference or two you can mention compared to like what you've seen abroad versus how it works in Georgia in terms of healthcare?
It's completely different in every country where I was. It's completely, I can say, but it gives you a lot of things. Like when you're performing the surgical state, it's same everywhere. It's the same in India, in Turkey. It's same. But the difference, even with the people, I can say, like the parents of the children or somebody who is waiting outside the door of the surgical room, they are the same. Like I had one moment in Canada when there was performed surgery, like for it's a specific type of done for the epilepsy, like for resistance epilepsy, and like this surgery takes about like 5 hours overall. And somebody outside, when I came out from the room, was asking, why are you doing so long? Why the patient is sleeping so long? I can't understand what they're happening. And it's same everywhere. It was same in Kenya, in Austria, in Turkey, in Georgia. People just don't get that you're performing the surgery on brains and not something else. The people are same everywhere. But for the other side, the only thing what I would change in Georgia, it's the organization. The other stuff, I can say that our surgeons are working in the same level as in US. And I can say clearly now that we have the same opportunities and same microscope and the specific instrumentation what we need to prepare surgery and doing the surgery in Georgia. And maybe I would bring some different to help the Georgian medicine. All. And
great. Okay.
Yeah.
Okay, so with that, I think we reached the end of the interview. So if you have anything to add apart from, guys, get a hobby, obviously. It's like, especially during Corona times as well, because, you know, we're locked in as well. So, but then, is there anything you would like to leave with?
The only thing I say that if you want to be a doctor, to be a doctor, is the most precious thing in the world, I can say, because it's great. Like to be a doctor, it's completely different thing. So nice because like when you see a patient, like of course it's very hard. I'm not that it's easy. It's always to be a doctor because always like it's the people's brain. I can say like this that it gets more negativity than positivity from people. We all are in the same position, I think. Where if somebody will say to you something, will remember that. He will tell you 10 good words. So, yeah, sure, but like, and I think that my best be that get positivity from patients. Because when like you see that patient feels better and you see that everything is getting better, he comes to you and he goes like from behind the door and just smiling to you, hi, saying like this, or he runs to you, he hugs you.
That's one of the
it's
great
completely different thing.
Well,
Yeah. Once the patient can make like one thing, just make your day. So if you will learn get that positivity from patient, you will never be able to get negativity from them as well. Of course, it will be hard times, and I'm not saying that it is all covered with the pretty flowers and all the better stuff, but if you learn how to get positivity from patients, then you will be the best doctor the first time, and then you will always smile with the patients.
That's a great point. Yeah, it's a cycle. It sustains itself.
Yes.
Right?
It's aging. And like it's I don't know how it happened, but when I'm going to the clinic, I always try to smile because like even like I have a hardest day and even I have the like deepest that like hardest pressure on me, like when I try to smile and when I see like 5-year-old child is running to me and smile, it gives everything to you. Like it's when you have a very cloudy sky and black sky and suddenly the sun is and everything has to be in the best way, it's the same. So I hope that all of you, all the students will find their field when they feel in the same way as I'm explaining now.
Great.
Yep.
So thank you so much for doing this. On behalf of everybody in the USMD program, everybody listening here, there were 2 or 3 points there that were very important. The burnout, the sunshine you were just talking about. This was a great conversation, Dr. Lika. Thank you very much. Hope to see you soon.
Yeah, very much. It was a pleasure for me to be here.
Yeah,
I
hope we meet again soon.
Program.
Yeah.
Thank you.
Yeah. All right. Goodbye.
Yeah, sure. Sure. Yeah. Bye. Bye. Bye.